All right. Hey guys, what's going on? Lee Sauerbutts here, and I just wanted to introduce you guys to Dr. Robbie Wolkers. He is a physical therapist in Northern Virginia, Gainesville, I
hmm
believe, right? Yeah. And owns, for what, about a year and a half now, Haymarket Physical Therapy. And
Yeah, we took over about a year and a half ago, Lee.
okay, sweet. So that's riding the roller coaster of private practice ownership, right?
Yeah, it's been an interesting bird actually. I thought it was going to be, I don't want to say easier, but it's definitely been a lot of speed bumps along the way. But I think we're finally getting off that roller coaster and kind of heading more towards that lazy river. But
There you go. Yeah.
yeah, I think that'll be good.
Cool. All right. So what we're going to talk about in the webinar here is just basically we're looking for people who are. I mean, this is specific for WebPT, but like we had talked
hmm
about, you could basically do these same hacks on any EMR system that you're using. So, but our goal is to be able to cut your documentation time down for like initial evals by 50%. So Robbie's going to kind of walk you through his process of how he's done that. He shared it with me, and I've been using it for about a month, and it's helped tremendously. So super
Awesome.
pumped and excited for you to share this, and we'll get this out to the world of private practice. So yeah, go ahead, man.
Yeah, I think the biggest thing is when we talked a couple of weeks ago, I was, just kind of giving you some tips there, and then you reached back out and said, "Hey, this is some pretty valuable information." And I didn't realize it at the time, but I was like, "Yeah, I guess a lot of owners probably need this information." So, without further ado, what I'm going to do is kind of walk you guys through the process of what exactly we're doing here. When we first started out, I mean, so just real quick background is I'm still working in the business. I'm still treating about 40 hours a week and then doing admin work and all that. So I really didn't have any time to be doing documentation, um, an hour, 2, 3 hours a day. So one night I just kind of sat home and I marked down every single thing that was slowing me down, and then try to come up with a system to get either our front office or our text or myself, and really try to get this thing more automated, so that when I do a note, it really is like, I think we're down to about 60 to 90 seconds for a daily note. I think evals, after I do a little bit of front end stuff before my patients get here, honestly anywhere between like 5 to 10 minutes, depending on how much I was able to get done before they got through the door.
Yeah.
Um,
So
prog-
yeah,
yeah.
for me, like my daily notes were probably about 5 minutes,
hmm
and the evals were killing me.
Okay.
It was probably like 20 minutes or something like that. So
Yeah, I remember you saying they were like almost like 20, 25
yeah, it was
minutes. I said,
insane.
Lee.
I mean, I was basically doing like 3 an hour, and
Okay.
it was just like, oh, it just sucked the energy and life out of me. So
Yeah, and I think I texted, I said, "Hey, I just did 9 evals in like 42 minutes." And you're like, I don't
yeah,
understand.
it's like, teach me your ways, man.
All right. Well, without further ado, let's go into kind of one of the biggest things that I noticed up front is my Wi-Fi. So I got my phone here. I don't know if you guys could see this, but I'm going to walk you through kind of the
We'll post a
process.
link. We can post a link in the
Oh, okay, great.
yeah. So
So what it is I downloaded the app called Speed Test, SPEEDTEST. So if you just go to the App Store and download it, it says, there you go, Speed Test.
yeah.
So it just says begin test. So then the first thing that I'm going to do is just hit the test button. So it's kind of going to test my Wi-Fi here. So the biggest thing I always see is practice owners, working on some real shoddy Wi-Fi. So there you go. I'm in my zone there. It's all the way up.
So what are
It's
we looking? What's the numbers we're wanting on that?
Well, it really depends on what you purchased. If you're a Verizon or Comcast. So right now I'm rocking 34 megabits. So this is my home Wi-Fi, which is ideal. Right now, anything between 20 to 50 megabits. I don't really know what that is. I'm not even going to pretend like
Yeah.
I don't know if it's bandwidth or whatever.
Okay.
But what it is the guy told me I needed to be rocking anywhere between 20 to 50. Now at the clinic, I think we run a little bit higher commercial. So it should be like, I think it's like 50 to 75 is what we're rocking at the clinic. So like if you do this and you're only at like 3 or 2 megabits and you're supposed to be over 20, that'll give you a great indication that your Wi-Fi needs some help. Whether you got to get a repeater, which is like if you're ever in like a business where you could kind of see up on the ceiling, there's those blinking lights and there's like a little box. That's
Right.
kind of a repeater. So what it does is it takes your Wi-Fi box and it puts it around the clinic. So then that way you have hotspots around the office, especially if a lot of people put their Wi-Fi in like a closet, and then they're in the back office a couple of feet away and they're not picking up any Wi-Fi. So that could be an issue right there. So I highly recommend getting speed test. Just check your workstations. If you do not have Wi-Fi at a specific workstation, you want to contact your IT guys or just look into getting yourself a repeater. Maybe call your wireless provider or your Wi-Fi provider and make sure you're getting what you need out of your system. The other thing that I do, I personally really like working WebPT off of Chrome. I know some people like Internet Explorer or Microsoft Edge, but I'm really a huge Google Chrome guy. Just for a couple hacks that I like to do in the objective section, and I think Edge really does a nice job with it too. But for the most part, for the objective section, I really can do a lot of different things on Chrome that I like. One thing to know about Google Chrome though is it takes up a lot of RAM to get going. So like if you have like a smaller computer with less than 8 whatever that is of RAM, it might slow your computer down, especially if you have a lot of tabs open. So if you know you're on a little bit slower system, you might want to switch over to like an Internet Explorer or even a Microsoft Edge because or a Mozilla. Does really good because Google Chrome does take up a lot of storage when you try to launch it.
Okay, cool.
Okay, guys. So we're going to go into Lee. I think I gave you a sheet prior to that. We're going to talk about kind of the front office and what that kind of looks like. So, and what I did, let me see if I could pull up my list for you guys just to kind of follow along with me here. So what I did when I was coming into trying to figure this out is I wrote down a lot of processes that I could delegate out. And some of the big ones were authorizations, making sure that those were imported. We also wanted to make sure that, here we go, I'll pull this up for you. ICD-10 codes that were coming off of prescriptions and stuff like that were set up. And also the outcome measures were put in by the front office. The correct physician was put in. Also a huge one is labeling case. So what I did is I created some dummy charts here. So when you pull into a patient's chart, the things that should already be done is obviously the physician should be already in there. I have direct access for this one, but at the same time, you want to make sure that they have the correct physician. The other thing is insurance, and this sounds like elementary specific data entry stuff, but it really goes a long way with the pre-setup. And we're going to talk about the pre-day preparation next. But what I want to show you guys, ICD-10 codes. So a lot of clinics get denials off of ICD-10s, especially like if you're working with TRICARE, VA Choice, or some of the insurance companies that have a referral that's coming over, and the doctor already has ICD-10 codes there. Use those codes. You could add other ones, but so I'm going to open up this eval here. So, and I don't have any codes in right now, but let's just say like this person has low back pain, and you're a big low back pain might be the ICD-10 code that you put in, but maybe the doctor likes to put in, maybe if it's a TRICARE patient, you just got 24 approved visits and it's radiculopathy for lumbar region. And maybe you don't really use that code a lot, but I'll tell you right now, if you don't put the correct code in that's coming off the auth, you're going to get denials. Yeah. So I always tell the front office, whatever codes are coming over on the referral or on the authorization, make sure you data entry those up front. Are you guys doing that, Lee?
Yes. Yeah, we do that.
Okay, great.
We're either doing that, or if there's nothing on there, we just usually put whatever joint and put it as pain.
Yeah, and then I also and I could post it for you guys too. So I gave the front office a cheat sheet. So let's just say like they didn't have anything like Lee just said, like no radiculopathy, no low back pain, no shoulder. So they know like on their initial phone call, we call it an activation sequence. They're not just getting the patient scheduled, getting their insurance, and that's it. They're getting to know the patient. They're also talking to them like, hey, tell me a little about how it's going on. Is it your right shoulder? Is it your left shoulder? Oh, I'm sorry to hear that. So before they're off the call, they'll know what side body part it is. They'll know that, like, is it central pain? Is it peripheral? If it's neck pain, does it radiate down the arm? So they've been trained to at least ask some of the basic questions that we want. So then they'll put lumbar. So like this person, this is my wife. So I made a chart for her. So it says lumbar. So I know that when she's coming in, she's going to be a low back patient without radiculopathy. So now this would say lumbar/sciatica or a lumbar/radiculopathy if there was peripheral symptoms. So before this patient's even here, I know she's going to be coming in direct access. I know it's going to be a lumbar case. And then the ICD-10 codes, we can already say, let's just take this out. And then this is what the front office is doing. I'm not doing this. I'm just doing it for the demo right now. The front office will already have low back pain in the system, and they know to start at least to add for a plan of care. They'll be coming into their information here, patient info, and they'll be adding in the plan of care or even the auth information. So they could come down here. Let me make this a little bit bigger for you guys. And does your front do that too, Lee? They're for the prescriptions and stuff?
Probably not as we're work in progress, man. I'll just put it that way.
No, that's okay. So what I would do, and if any of you guys, like, if this is all elementary to you, great. So we're going to break this thing up into sections. You could just fast forward,
Sure.
but really try to take this in. Like, this is important because, like, if their evals on the 19th, okay, and then they're going to be coming for direct access. State of Virginia is 30 days. So 1, 2, okay, 3, 4 plus 30. So their end of date is going to be 8/18. Number of visits, we're trying to shoot for 12, 3 times a week for 4 weeks. Now, that could change because I usually do 2 to 3 times a week, and then I'll do duration of 4 weeks. But every single one of our direct access patients is going to be coming in 2 to 3 times a week for 4 weeks. That's going to be their typical plan of care.
Okay.
So then alert days prior, I usually do like 3 days before alert visits too. That just gives you an alert. Like, if you guys aren't putting this in, this is the ability to track your scripts. So if anything's expiring, or anything like that, you definitely want to be putting like alert days. That means 3 days prior to expiring, it'll let you know. Now you might want to do like 5 days, days prior. So then your front office could start working on some information, but visits prior too. So then this will usually flag it the week before the week comes up where it's going to be ending. So I add all this information in, and then I save it, save patient. Awesome. So before, I get this patient, I'm going to load it up and do some pre-stuff. I'm going to know that they're coming in for low back pain. They're direct access. Looks like their insurance will be a self-pay, so they're going to not be even going through insurance. Diagnosis should be here, should be extrapolated through. It's on my eval, but the front office will put it in the patient info so that it'll extrapolate in here. And now I have a plan of care.
So this is what it looks like when front office is done. They hand this to you right here pretty much.
Yeah, so when I go to pull my eval before the patient even gets here, I have a lot of good information that I could even start writing half of my, and I'm not even exaggerating, like I will write half of my evaluation before the patient even gets to the clinic, off of all this information that's there. So that's why it's so crucial that they do that. Now, one thing that I want to show you too, if you guys aren't doing it, it's probably, I'm like the cheapest guy you'll ever meet in your whole entire life. But like, there's one thing that I pay for and I love it and I don't even think about it anymore, is WebPT outcomes. So if you come down here to the outcome reports, it's a plugin that WebPT adds. And I think it's like $99 a month for an office. I think, I'm not sure the price on it at the moment. We got it a couple months ago.
I checked that out.
What do you know? What's
I think it was $100.
Okay.
A month, but I don't know if that was per clinician or per office.
No, just per office. It's a one fee per office. It won't be per clinician. And I know, sometimes things start adding up, but at the same time, this thing for like $100 a month saves me minimal, like 5 minutes on an evaluation alone.
Yeah. Right.
Because what happens is, like, I don't have the outcome measure. So I go into eDocs, I pull it out, I come in, I have a split screen like you're seeing now, and then I'm plugging in the information. So all I would do is go to add outcome. So it gives you the opportunity for 3 things. Now at the front office, we have a kiosk. So what that is like an iPad set up at the front. And if it's an older individual, you don't want them to be using the iPad. I get it. But if they're a little tech savvy, you can give them the iPad and they can fill it out. Fill out now is a great opportunity for you just to give the patient like a paper copy. And then when they bring it to the front office, your front office will hit fill out now and then fill it out there. And now it's in the system. And then also send a patient. So what you can do is like before the patient even gets here, you could send them their outcome measure and then they could fill it out at home and then they'll plug right into the system. So let's do fill out now. So I'm going to pull, we said it was lower back. So we're going to come and you only get 5 options, 1, 2, 3, 4, 5. So they really dumb it down for you. It's going to be initially evaluation and then go to survey. So let's just say the patient already filled this out and then they're going to get a PIN number, extrapolate through. I'm just going to add some, I'm just going to click a couple things real quick. So we're not going to sit there and fill it out, but let's just say patient came in, they wrote all the information out, they extrapolated out, great, and good, and then it's going to give you a submit. Awesome. So submit score, good, submit. So what this is going to do from our ends, so here's my WISE chart. I could go into initial evaluation before I even start to see this patient, and I could pull their outcome measure through. This is important for like Medicare, and I know you had a comment earlier, Lee, about so sometimes Medicare, we'll get to the pre-day prep in a little bit, but what Lee was running into is for Medicare, if you don't do down here where it has the functional and then it had like the functional code here, and then if you didn't do the outcome measure or the objective, when you do an assessment before that, it'll erase your goals, which is really annoying.
Yeah.
So WebPT, if you're listening, try to fix that.
Exactly.
But at the same time, what it is the subjective and I'll show you an example of that. But when you come into your goals, it'll pull your outcome measure through, but it'll delete any goals that you put here, which is a little bit of an annoying thing, especially if you spend a couple minutes on them. But if I come into here now, Lee, and also I pull the low back. And this obviously seems a little bit longer because we're explaining it, but I could, and I'll show you an example how I kind of just fly through things. But at the same time, so I'm just trying to go a little bit slower so you guys get all this.
Sure.
But you come down to Oswestry, great. And now before the patient's even here, they filled it out at home. It's submitted into the system, or our front office added it into the system. So once this buffer's here, it's going to give me the opportunity to select test. 7/19/2007, get score, great, and now my outcome measures in. So the only thing that really bogs me down here is maybe my Wi-Fi, but that's it. So all I do is select the date here. Now it'll give you this date, it'll give you your progress summary date, it'll give you your discharge date. So depending on what one you're on, it'll drop it down, but then it'll give you your disability, which I really like.
Perfect.
Okay, so and then just to kind of show you guys too, I think we talked about the ICD-10 codes going in. We talked about WebPT outcomes, and if you guys aren't familiar with WebPT outcomes or haven't done it, and Lee, I don't think you signed up yet, correct?
Yeah, I haven't done it yet.
All right, let me just show you kind of behind the scenes here.
And we can always reshoot this, man. So let me just give a little wave here so I know.
Okay.
Okay.
All right, cool. So I'm going to talk a little bit real quick about the outcome measures, outcomes reports. It's on the bottom here of so once you get that plugin, you'll get outcomes reports added to your clinic, and then you'll get some really cool reports. So if you're like a big KPI, key performance indicator guy like myself, or even Lee is, you're going to want, and it's kind of cool because you can see how your clinic ranks nationally amongst others. You can kind of see your clinic's report card. WebPT has a ton of different clinics in there. So anybody that's on outcomes and they're putting in data, you're going to be able to pull that information and kind of see how you're doing. Administrative reports here, patient reports. So any dissatisfied patients on an outcome measure, anybody missing discharges, your patient list itself, which is pretty cool. It breaks it down into diagnosis, patient pain scale progress. So it tells you like on the pain scale, per diagnosis, if they're getting better or not. Same thing with company reports. You could tell if your, company's getting certain diagnoses better than others. If you're overall getting people better, do you need to send more people to like continue education for certain diagnoses? So it's really powerful tool to use. So one thing that I've done.
Are you doing this like for like negotiating with payers as well?
Yeah, but that's a great question. So what we do is, so let's do pain scale improvement. So what you're able to do with like dates, you know, let's just say I want to do like last quarter, and then I could show, you know, all the therapists. Now I come down here to pair classly.
Mm-hmm.
So, so then what I'll be able to do is I'll run like a report for, probably won't be renegotiating contracts with Medicare, but
Medicare,
let's
yeah.
let's try to renegotiate with like Cigna. And then now if you're in network and you're getting like a lower capitated rate from Cigna and you want to go from like maybe 70, 75 up a couple bucks, I run these reports and I'll say like, hey, listen, these are the people that came into the clinic that had Cigna insurance. And this is what we went. We went from like 6 out of 10 pain average down to 1, down to 0 out of 10, in an average of like 8 to 10 visits. So to give you an average range. And then you'll have this outcome objective data that I could put it in a letter and give it to them. And then I get a really nice response there. The other thing you can do is you come over here, you go to physician, you type in a physician here, you run a report for all the outcome measures, and you say, hey, you know, Dr. Who, so-and-so,
Yeah.
here's a breakdown of your last quarter patients. We saw them, and we got 85 to 90% improvement on all your patients. Send us more.
Sure.
I don't need to go, and I don't need to, you know, knock on the door and bring them lunch or market to them. I just pulled a report. I put in the letter. I write a little, thanks for referring patients to us. Here's your outcome measure. And boom, I send it off every quarter. And
Awesome.
then you get patients coming in that way. So I really love that tool for it, especially if you guys are doing like those letters to physicians. Really powerful to be adding like a breakdown of their outcome measures reports in here.
Yeah.
Really powerful. So,
And this, I think we talked, what is this, like about $100 a month?
yeah, this is,
Cost?
I think WebPT, yeah, it's not per clinician. It's not anything like that. I believe a $99 charge per month. Now, if you're a smaller clinic, you know, and you're not really too concerned about being bogged down by your notes and stuff like that, and you know, you might not have a lot of the data, you know, I'm not saying to not get it, but at the same time, you might want to, you know, look into your expenses first and then purchase it. But I love, like, if you're a bigger clinic, I mean, it doesn't get much better than this. We love data. We love it on the palm of our hands. And there's so many different reports that I can run
Yeah.
outside of billing, objective data. So now those functional outcome measures, when everybody's just like, oh, well, why do we need them? Like,
Right.
now they actually mean something.
Right.
And I could pull so much information off of it. It's ridiculous.
Yeah.
It's great. I love it.
Getting a lot of mileage out of that instead of just the convenience of uploading it into the report. There's some
Mhm.
other, you just got to dig a little bit deeper to find those extra benefits. So
Yeah, and
cool.
then just a real quick plug, even from a patient standpoint. Hey, how am I doing? So before their progress summary, we have the front office run this report, and it gives them a little graph of how they're doing. So,
Yeah.
so I'm
Cool.
just like, hey, like, here's your graph, and you're not better. You know, what's up with that? Or hey, you look at, you were here, and now you're up here. Like, you're so much improvement on your outcome measure. They're like, oh, you know, I guess I am improving better than I thought.
Yeah.
And then it has a different conversation. People love those visuals.
Yeah. Cool.
Okay, awesome. So what we'll do is we'll take a little bit of a break here. We'll start the next video here of kind of what I do prior to patients coming in the clinic. So what we're going to do is we're going to talk about my pre-day preparation. So basically, everybody should be doing a chart review. So basically, like, let's just say I have my schedule here. I got a slam pack schedule. I got four people coming in.
Ooh,
But at
I used to love those days, man.
the I love to open up all my notes prior to. Now, you don't have to keep all the tabs open. So what I do is I'm holding down Control on the keyboard. I hover over the name, and then I left click on my mouse, and then it's opening up new tabs up top without. So like, if I didn't do Control, this is what would happen. Okay, now I'm going to click back to schedule. Now I got to load the guy. Now I'm going to click here. So what I do is
Say
if
that
you
again,
can,
because
so if you're,
I
yeah, if
haven't done
you're,
that, man.
so if you're on Control,
Okay.
okay, so I'm hovering over the name. So I'm going to get off the name here. I'm going to click Control on the bottom left of my keyboard.
Yeah.
I'm going to hover over Marilyn Monroe here. I'm going to left click on the mouse, and it opens up a new tab for me.
Cool.
Okay.
That's
So
awesome.
that way I can open up all my tabs here. So you want to be sure you're not standing next to a patient and loading their note.
Right.
It's so frustrating
Yeah.
when it's not loading and whatever. So they're all loaded now. So I load them all up. They're all taking their little bit of a time here. But at the end of it, we're going to be down. So I don't do SOAP notes like we were taught in clinic, Lee. I do B, especially on WebPT has this billing tab. I do BPAOS notes because you can argue that there's nothing more important than the billing part in the note, especially as a clinic owner, than the plan, assessment, objective, and subjective. I mean, how many times have you seen, like even myself when I first started was just like, oh man, what did that patient say? Oh, when was their eval date or when was their date of surgery? And you spend about like 10 minutes just thinking about what they said. And then you move to objective and data entry, and then you're like, whoa, let me rush to get this note done. And you rush the assessment plan of billing, which is the most important part. So what I do is I do billing first. So let's just say he's coming in for low back. So, if you're a new clinician, you might not be able to do this as quickly, but I already kind of know for the most part what I'm going to be billing for most of my evals. I mean, it's usually going to be an eval, maybe one or two codes on the backside. We do ice and stim here. So I'm already going to kind of, now I usually don't do Therapex. We do manual on the first day, and then I'll definitely educate them and we'll do some more functional activity with them. Now I could change the minutes here. That's no problem when they come in. I'm just putting in some like placeholders.
I was like, you forgot your little sneaky hack there.
So my plan here, everybody clicks down and then they got to go to the next one. And then they got to scroll down, and then they got to scroll down to neuro. So when you click from top down, what happens is the boxes drop down and then you have to scroll. What I do is I just go I start on the right-hand side and I work myself up and I click on all my stuff here. Great. And then I go to patient education, and then I go to we do manual neuro. He'll do all that stuff. And then I could go down and click my boxes here going this way. So then that way things aren't dropping on me and getting in the way. Does that make sense?
Oh, for sure. Yeah. That was huge for me when I started doing that. You wouldn't think like 10 or 12 seconds doing that, but I mean, all that stuff.
But off of 8 evals sometimes people have. Sure. It's crazy. Yeah. So just real quick, just dropping down, you can see how I'm dropping tabs down. If you start from the bottom, the tabs drop and you can just click going up. It's just a really small hack. So now their plan's done. So I got their billing done. I got their plan done. Assessment. Okay. So I'm going to come over here to the assessment portion. So this smart text, like if you're not using smart text, I don't really know how you're functioning on WebPT. And then because WebPT threw a curveball on me, they added a couple new tabs to the smart text, which is awesome.
Yeah, they did that like a week after we talked, man.
So I got to do more stuff, which is fine. But at the same time, we could definitely, because I think they added history now, and then they actually added an assessment portion. So I used to do the patient education, copy and paste and put in assessment, but now I'm able to do the assessment. Goals are huge, which is another one. Patient education, so all the stuff that you educate a patient on is going to be right there for you guys. So what that looks like, I know they're going to be coming in for low back pain. It's great, no radiculopathy. So what I do is I type the word in lumbar here. So all you guys would do is type in the word lumbar. So did they get a fusion? Did they get a laminectomy, discectomy? Did they get sciatica? Did they get stenosis? Or is it just regular low back pain? For now, we're just going to put regular low back pain. My problem list, I'm going to put in.
This was huge right here, man, for me.
Yeah. So then right here, low back central. And you've been implementing this, Lee?
Oh yeah. I mean, like the next day I started doing it, man. So
so then all you do is just lumbar. You could take out lumbar now. You could come down here, and I just put it here so it's easy to find. You just type in the word that you want to use, low back central. So hopefully I didn't go too quick there for you guys. So if I type in low back here in the problem list, so low back central, low back peripheral, low back stenosis. I mean, so then what we want to do, is we go to central. Okay, so then that way there, and then I come back down here, lumbar, and now I have lumbar goals made. There's my lumbar list.
So the one thing that I was doing on this, like I would do, I'd have 4 or 5 goals, and I was doing pretty much the same goals,
Yeah.
Show that little how you can slide that open, grabbing the lower right corner of the box.
Great. Yeah. So what Lee's talking about here is if you go to active here, and then I go right here to the bottom right-hand corner, I'm going to slide that down. And see, it looked like a paragraph, but realistically what I did is I have them all spaced out.
Yeah.
So then let's just say you're in here and you want to customize your goals here. Well, maybe they're already working. They don't need to return to work without modification, and really they don't have pain with sitting or standing. So we just want to increase their score. We want to improve their oswestry, and then we want to improve their range of motion. Google Chrome allows you to pull this down. Some of the other ones might be able to too, but I really like Chrome for this reason, is because I have this opportunity to pull my tabs. Same thing up here, so it doesn't look like scrambled eggs, low back pain.
When you go to print this out too, it looks like instead of one
It's
goal, it
sleek.
looks like, yeah, it looks good having it screened out like that.
Yeah, I get a lot of compliments from physicians. They really like it. Or what I can do here, is I could copy and paste this. I could copy and paste my two goals. So what I do, Lee, is I might do a case note, copy my assessment, copy my goals here, this breakdown, put it in a case note, and just send it over. I'm going to spend a little bit of time here on objective, just to show you a couple hacks that I love. Same kind of concept that we talked about in the plan. So when you drop tabs down, it really is time consuming. So a lot of times you might want to start from the bottom and work yourself up. So that's good. A lot of this stuff here, you can make custom templates on WebPT. I just like what they have because just in case I forget the test, like WebPT does a really nice job of like, what's the Bragg-Arts test or, the sacral tuberous ligament stress test. It's like, well, I don't know. Let me YouTube it and check it out. And then I could at least go back and check on some things too and just keep my knowledge up to date. Palpation, yeah, good luck. Great section, WebPT, awesome. But I'm going to go here to additional comments and just write what hurt when I palpated it.
Yeah.
Additional comments is your friend. So two things that you can do. If you like starting here and tabbing down, if you click on this button, hopefully you could see, well, here, let me try to increase my zoom here, Lee. Okay, cool. So what I'll do here is, and then let me bring this up higher, and you could see that, right?
Yep. Yes.
Pretty good.
Yep.
Okay, so what I'm going to do here is I clicked on NA, and I'm going to tab, and as you can see, is I'm tabbing through. Okay. Yep. So a lot of people, for whatever reason, didn't realize you could tab through to the next one, and if you did, great. But if you tab and you use the arrow keys, so now I could use the arrow keys, and I'm not going left or right. You could go right or left. I'm just going up or down, and it's going to put me in these spaces where it drops tabs down. So it's here, and now I could tab to drop to my box. I could tab again to drop down. I could drop my arrows if I wanted to include extremity reflexes. Maybe I don't want to include it, so NA, and then I'm tabbing through this way. Myotomes,
So all you're doing is tabbing right there? Or
I'm using tab and arrow down. So right now, so when I use the arrow, see, this is what arrow does.
Yeah.
Is it drops the myotomes down. Let's just say, I don't want to use myotomes. I'm going to put the arrow up, and then it closes that section out for me. Okay. So then what that looks like, let's just say myotomes, let's just say dermatomes. So I just clicked here. I want to include dermatomes. Great. Now I'm going to tab through normal. Well, let's see, these were all normal, except for down at L5 was a little hyposensitive. I dropped. So I'm now in the section, and I'm using the arrows to toggle through. Or you could just hit the letter. Like if you know hypo, you could just put an H and it drops it down to hyposensitivity. Tab over, hit H. At lateral foot, there's some hyposensitivity there. I'm just hitting H because it drops it down. If I want to hit slight here's my options here. Now if I come here, click, no sensitivity, hypersensitivity. So you could toggle through. Like if I'm here, and I hit H and then hit H, I'm hopping through the two H's. Gotcha. If you could see that. Hopefully it's not lagging. Yep. Or I could just do arrow, and now I'm toggling through all of them with arrow.
Okay.
Now what that looks like when I'm clicking, normal, hyper, normal, great. It just, oh my gosh, it's so slow. So let's just go here. That's no sensation, or let's do, so there's no sensation, and then normal, not test it. So I just do normal, all through there. Let's click that. That was normal. Toggle through. So I'm just hitting. So, and then the other thing too is if you have three words of the same, if you just hit normal or N, and N, it's going to toggle through the three N's. I click to the next one. I want to do lower reflexes. They were all normal. Yes. And now all of a sudden I hit yes for here. So then, because then that way I don't have to keep hitting like 2+. Just hit yes to create them all equal. And then I could toggle through and then change it to 1+. So up arrow toggles through all, down arrow toggles through all of them that way. or I could just hit 4 and it's going to toggle through all the 4s. I could hit 3, it'll toggle through all the 3s. I could hit 5, it'll toggle through the 5. There's my 3s coming through. So I really love that little pad of numbers on the right hand side.
Mm-hmm.
Just make sure your number lock is off, because if that's or on or whatever we have to do, sometimes you'll be tabbing and it's not working and you get frustrated. But and then when you get good at being a PT, you know that there's specific ranges that most people usually fall in. Like if I said hip flexion, Lee, what would be like the range of motion for hip flexion?
Oh, like
for most normal people, no restriction. Yeah, like 120 to like 125. So you could put before you even see them, like 125.
Right.
And then like if there is a limitation, you could toggle down to the limitation.
Gotcha. Yeah.
So like these could already be in the system prior to them coming. Let's just say they're coming in for knee pain. And if I want to hit them with like, let's just say younger person should be like 140, 130.
Right.
I tab over 130 and then 0 and 0 for extension. Yeah. Now all of a sudden they come to the clinic and they're at 110, and then they maybe lack 5 degrees of extension. Now I just did that really quick. It's already in the system.
Right.
And then you could go through there. Your baseline's
I
there.
mean, those things that catch your eye, you've got to just adjust that instead of having us hunt it down or search for it. So
yeah, and like I said, patient's still not at the clinic yet, and your objective's done. So that was, we went through all there. So the subjective portion here, just to kind of show you if it's done right. Diagnosis should already be in the system. Treatment diagnosis, you might add a couple of different codes for it. The front office should already have like what body part, so you should know it's left or right. Injury, or if you don't do anything in the eval room documentation wise, please make sure that you do the injury and then the date of surgery, because these are the two that what was the date? And you go to the welcome packet, you're flowing through like a flow chart. You're looking at it's just a mess. So at least when you're documenting with them, or if you're in the room, get these two down. Okay.
So when you're going in the room with them, are you got an iPad or laptop or paper?
Yeah. So my setup is going in. I think you guys have the kind of the similar setup. I'm an iPad guy, with the keyboard. So I got the Bluetooth keyboard that I could just take my Apple, I think it's an iPad Air, flip it up. So now I got a keyboard too.
Yeah.
Small disclaimer though, the Apple's really restrictive, like an iPad. Really cool hack. You could dictate with an Apple iPad.
That's what I do. I dictate.
Yeah, you don't need Dragon technology. You don't need anything like that. You could dictate. You just hit the keyboard and just hit that mic. Hey, patient tolerated today's session well with minimal complaint of blah blah blah, and then it'll extrapolate it in for you. Yeah. If you do that, the only thing is some of the tab features are a little wonky. So what I do is the stuff that I could do in the room with the iPad, or if you have a laptop, great, even better. And then I come in the room like on a desktop and I really hammer out my notes pretty quickly with the tab feature, going that way. And then also I'm a big split screen guy. I like to have like a couple things going. I like to pull all my evals up and do all my evals together because there's a better flow there. Yeah. I like to do all my daily notes together. I group them like my progress summaries. I do all my progress summaries together, and then my discharges. So a huge thing that's been so successful for us is documentation, and documentation is like it should be EMR, and our welcome packets are scanned into the chart.
Okay.
So that is part of the EMR. So you need to take your welcome packet and you need to make sure that every single one of these things are on your welcome packet. Because all I do here, like diagnostic testing, I say, see welcome packet.
Gotcha.
Because it's there.
Right.
Any complications. Well, I just took all these here that are in WebPT medical history. I did all these. Like I did Alzheimer's. I did every single one here. And now I could just go here and just paste see welcome packet. History of falls. Like on the welcome packet, it says, do you have a history of falls? Yes or no? If yes, it has like a little sentence or two. When was your last fall? Blah, blah, blah. Are you Medicare and with home health care? Yes. Are you currently discharged? And I said, where am I getting tripped up at? Yeah. It's like, well, all this stuff is they put it on the welcome packet, and then I'm going to go in and data entry it. No, just scan it into eDocs, and then just say here, just refer back. And I asked insurance companies that if that's kosher, if that's good. And they said, yeah, it's part, like their welcome packet, their patient intake is part of their EMR. So yeah, and then just if you guys missed it, like all I'm doing here is just saying see welcome packet. So see welcome packet, and and then here, and then patient goals will kind of tap into what their goal is here.
Yeah.
All this stuff has to be on your welcome packet, all the subjective, and then your eval's done.
All right. On your marks, get set, go.
Okay, so what I'm doing right now is just waiting for the note to load, which is always half the battle. Okay, cool. So I go to billing here. So she's right knee pain. I'm going to do low complexity sports injury, 15. Usually do manual here. Good. Let's just say they have a ligament strain. I'm going to go with an MCL. Okay.
Yep.
Let's do an MCL. This all looks good. Great. Great. Good. We want to return to sport. Awesome. Sport. Awesome. Good. So while that loads here, I'll go to subjective. Not wasting time. It'll load while you're on the other section.
Really? Okay, cool.
Yep. So let's just say she got hurt June. I'm just, I could gather this information from a welcome packet. I would have a split screen here.
Yeah.
If it's in the system.
Gotcha.
No surgery. I'm going to fill this out from there. Probably do mobility for a knee. Right knee pain. I'll wait till I get a welcome packet here. Usually good. Other. See welcome packet. Great. And then we'll get our goal later. So I come back to objective. This should already be down for me. Great. Yep. So no time wasted there.
Mm-hmm.
If you start typing things while this is loading, it'll knock it off. It'll get rid of the work you did. So I do have to wait till the outcome loads.
Okay.
Slow me down. Awesome. Good. 51. Good. Patient reports. I usually check ASIS. Weight bearing. Full posture will do. Training. Muscle atrophy. Ankle, knee, hip. Good. Okay, good. So that's my pre that I would do, and then I would save it. So where are we at, Lee?
3 minutes and 40 seconds.
Okay, that's pretty good.
I feel like a NASCAR, pit crew.
So that was 340. So yeah. So now if you have like 3-4 evals coming in, you check your schedule out beforehand. You might want to give yourself like 15, 20 minutes just to kind of open your notes up. Or what you can do is open up your 2-3 evals for the morning. And then in the afternoon, because some people cancel and stuff, you don't want to waste a lot of time on the afternoon if you're gonna change in appointments or swing to different providers. But at least if I have my morning done and then at lunchtime, if I got a second or two, I could start opening up some of my notes. Or when you're wrapping up with that last patient, you can do the same thing too. So now what I'll do is, Lee, give me a couple stats and then I'll kind of plug them in here and then finish up the note.
What kind of stats?
Just give me like, so right knee pain.
Oh,
Maybe
right.
give me like just some limited range of motion.
So
Just give
just
me
a
a
little
couple.
subjective.
Yeah.
Okay. So I got pain going upstairs, like 3 out of 10. Coming down, it's about a 4 to 6 out of 10. Sharp stabbing.
Okay.
Been going on for about a month.
Okay.
Anything else?
Give me a range of motion for the knee.
Okay. I'm like 110 for flexion and like 5 degrees
Okay.
lacking
And
extension. Yeah.
and then give me a number for glute medius strength on the right.
+3.
Okay. And then left leg's 5 out of 5. Everything
Yeah.
looks good.
Mm-hmm.
All right. We've been going at this for a little bit, so hopefully I'm not too fried here.
I know. I'm like, I don't ask me to remember that stuff. So
I'll be like, give me like plus or minus, but I'll try to make it work. So
okay.
so just to recap, Marilyn, so about a month ago, started having knee pain going up and down stairs, not able to run, about 6 out of 10 pain. And then she's at
110
5,
degrees.
110.
Yeah, 110 flexion.
110, and then 5 degrees lack and extension, and then a 3+. Okay.
Yep.
So then what I would do is I'm going to come. Oh, here, go ahead and start it if
All right.
you didn't.
On your mark, get set, and go.
Okay. So coming into billing, so she was a little complexity there. We did heat, stim, and ice. I did manual for 16 minutes, and then we did this for, let's say, 10. I gave her home program, so that's confirmed. Playing here, everything looks good. She's coming in direct access, so I'm not going to change anything there. What I do want to do is maybe send a dry needling script over to her PCP. So I'll include dry needling, and then I found out who our PCP was, so I'm going to put it there. Coming over here, grade 2. It wasn't a grade 2. It ended up just being a grade 1, MCL, and then no meniscus. It was just MCL. Loss of range of motion, strength, functional mobility. Great. Patient will require 6 to 8 weeks. Nope, she will require 4 weeks of inpatient, and 6 visits will be referred to MD for further evaluation. Great. Active. Pulling this down, unable to walk. Negotiate steps. Stand good. Run job by this time. Sore in the AM. She was not sore in the AM. She was negotiating steps. Great. We have that. Sports. So we're going to bring this down. Increase lower extremity strength to 5 out of 5. It's a little 3+ to a 4+. I'm okay with it. Single leg squats without bilateral extremity support. Good. Treadmill. Great. Everything looks good there. Awesome. Coming over here. Now the fun part. This is where we're going to make up some time. So coming through. Posture was normal for the most part, except for she did have some flat feet. Gait, she had an antalgic gait pattern. She lacked knee extension, and then she had apprehension walk and stride. Let's just say atrophy, right quad and gastroc. Edema, maybe like infrapatellar. And then let's get the magic going here. So 110, 120. There you go, 120, 0, 5. Right knee was 110. So let's do 135. There it is. 0. Cool. And ankle dorsiflexion. Let's just say she was a little limited. 10, 15. I'm just making up numbers now. So.
Sure. Yeah.
All right. So then we have flexion here. So let's just say a 4. Let's just say 5. 4, 5. Abduction was a 3+. There you go. 4+. So 4 minus 4. Okay, good. This all looks good. Great. Special tests. Let me get my meniscus, and we definitely want to make sure that that's negative, because we rolled that out. And then we're going to come down here to ligaments of the knee. Same thing for drop down. So we did Lockman's anterior. We did these guys. And then we said an MCL. So she was positive for the right. Positive, negative, 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 negative. Awesome. Let's throw a pivot shift in there just to make sure. Good. Patellofemoral joint mobility. Yeah, she probably super. She was hypo, normal. So let's do normal. Okay, palpation. Patient tended to palpate over medial or MCL and okay, great. And subjective here. I might have to pull let's do some right knee swelling. Sometimes like you might get tripped up on your codes. So what I'll do is I'll just come back to that so I don't waste any time here. June, new injury. Patient started. Mm-hmm. How are we doing on timely?
5 minutes, 40 seconds. Pretty good.
I put patellofemoral, but let's do MCL. Sometimes like finding the ICD-10 every now and then it trips you up, but that's okay. ICD-10.
You need to put that tab in your favorites, man. ICD-10.
That's it. So there you go. And this initial. So we'll just do this one here. Yep, there we go. And copy codes and complete. So then I'll do billing and I'll send that off and then we're good.
Pretty good, man. I was about right at 10. You had about a minute blurb on with the ICD-10.
Yeah, and I think once you kind of get, you always get tripped up on something.
Yeah.
But at the same time, so like pre we did like 350.
Yeah.
Maybe like we'll call it 4 minutes. And then afterwards, like doing, so like clearly in a half hour one-on-one with the patient or even longer, you could easily get your note done right there bedside.
Yeah.
So you really shouldn't, like when you're done for the day, you should be done for the day. If you have notes hanging over your head, it's definitely your fault.
Yeah.
So no one's else to blame. But yeah, I think that's just kind of how I do it and kind of brainstorm. And then you kind of saw me go back and, update some stuff. And, I caught that in here, it was 6 to 8 weeks, but we're direct access. We're going to do 4 weeks and they don't have a doctor. So we'll refer them over. I updated a couple of things here. So it's templates, but you customize them, but you're not putting everything. I mean, how long would it take me to write everything here out?
Right.
Now when insurance gets this, our claims that get denied, I hate to say it, are just for lack of auth.
Right.
I mean, we don't really get denied for anything else, for the most part, other than just visits, making sure that our auths are good. So that's why, we're making sure our front office is, getting the Optum, getting the Aetnas, getting all that stuff, TRICARES. But at the same time, we're not really getting denied for too much because the notes are, pretty robust. And so hopefully you learned something off of WebPT, at least if anything.
I got at least four or five pearls just going through this again, man. It's awesome.
Cool. So and this is one of those videos, guys, like to really put some time into. You might have to watch 1, 2. I mean, this is Lee's third time kind of talking about the stuff, and he's still getting information. I think the more I talk about it, the more I get more information.
Sweet. Appreciate it, man.
Awesomely.
Awesome
Yeah, well,
stuff,
thanks for
bro.
having me on, Lee. I really appreciate it, and good luck to everybody out there with your documentation.